we better get cracking. We've got to get through, we've got 4 cases, so we'll see how we go. So just firstly, just to, everyone's all well aware of this, this newspaper article from an incident in 2015 highlights the risk of OAT being ingested by children. Indeed, the ingestion of OAT by anybody that's opioid naive is associated with the risk of overdose. So while young children of parents prescribed opioids are at increased risk of overdose, in Australia, these cases are very rare, occurring estimated once every 2 to 3 years. In this webinar, we're going to work through some case studies to consider some conundrums that prescribers face when considering the provision of OAT takeaways. So decision-making around New South Wales health guidelines for takeaways. Generally, treatment of opioid dependence with methadone or buprenorphine is based on daily supervised dosing at a pharmacy or clinic, and access to takeaways or unsupervised doses is available according to individual patient circumstances. And in this slide, you'll see table 15 from the New South Wales guidelines concerning case flagging in OAT. And this case flagging matrix is helpful to help you decide the potential risk category that your patient might fall into and how to decide whether takeaways are feasible or not. Essentially case flagging considers adherence to treatment, whether there's concurrent substance use, their medical and physical health, if they're pregnant, and what their social circumstances are, in particular housing, domestic violence, and whether they're living with children. Now, just to prepare you for the case discussions, we're allowing about 10 minutes per case, including your thinking time, jotting down some notes, discussion, and completing an anonymous online before and after discussion poll. We've planned 4 cases to discuss tonight, but we'll see how we go for time. Now, you've got your pen and paper or electronic notepad ready, and you're ready to jot down some points as we bring up the next case. And as I said, Daniel will put up this pop-up poll for you to nominate whether you think you will prescribe or you won't prescribe takeaways. And please don't spend too long agonizing. We don't know who's saying what, and it's just your sort of first thoughts, particularly for the pre. Now, this is the first case. And as you're thinking about this case, think what case details are important. What else would you like to know? Would you prescribe takeaways? If yes, how would you prescribe? And if no, how would you manage this patient's requests? Now, take a minute to consider the case here, jot down a few points, and then in a minute or so, Daniel will pop up a poll. And I'll read it out. Mr. RN, a 34-year-old male on methadone, 150 and 30 mils daily. He's just out of prison, released 2 weeks ago, and wants to visit his brother who's unwell and lives in a rural location about an hour's drive from the nearest pharmacy. He would like to stay for his brother for a week. So in this case, in the decision-making around takeaways, what details are important? What would you like to know? What else would you like to know? Would you prescribe takeaways? And if so, how would you prescribe? And if no, how would you manage the patient's request? And I guess you could, is everybody sort of ready for the poll in a second, you reckon?
I can launch the poll now, Sharon, but just a reminder, everyone, you'll see a poll pop up in a second, and it will just basically ask on face value, do you think you'll prescribe takeaways for this patient? Simply yes or no. It's completely anonymous, so feel free to answer as honestly as you're willing. Yeah. And I'll start that first poll. And Sharon, I believe, because the results are streaming in now, we'll probably share the results at the end of the discussion as well.
Yeah. So we'll do a pre and a post and see how they compare.
Wonderful.
Okay.
So I think we've got most people have responded to it. I'll leave it open for a little bit longer. Nope. Okay, it looks like I think there's 1 or 2 people, but I might end the poll just for brevity.
Yeah.
Yeah.
Okay, so open the floor. So what does everybody think? What's your sort of first thoughts about this? And, you know, what are the features of this case that need consideration? And Dan, you could, as I say, you can raise your hand, flap your hand. There you go, Chris. And Dan, okay.
So I'm a GP, but I'm currently working as an addictions BMO at St Vincent's Hospital. So I guess the notes that I jotted down was that this guy's a new patient, so we've only known him for 2 weeks. He's on a high dose of methadone, and that so my gut instinct was no. However, I think if we just need a bit more information. So I think I would certainly want to know if we've had a clear urine, a bit more about what his background is. Is he currently using? Is he actually safe to drive on a high dose of methadone? Does he drive? Does his story check out? So do we have like his brother's address and his pharmacy address? And I think if I've got a good rapport and I really trust that this story is real and everything, I'm happy with everything else, I think I probably would try and maintain my relationship with him and say perhaps negotiate maybe an alternate day takeaway for 1 week after chatting to the pharmacist, and if everything else lines up. So I actually ticked yes. Maybe I shouldn't say that in the poll. Assuming everything would check out.
Yeah, great. Thank you, Chris. So what does everyone else think about what Chris has said? Anything to add? Any sort of, any other information you think we need? Anything else that stands out about this case for you?
Or even someone in a regional area, perhaps. Do you have your own perspective that, or perhaps previous client with a similar circumstance? And if you don't want to unmute yourself, feel free to type in the chat box as well. Don't forget.
If I may say, the vast majority of people said no. So yes, Gavin from Lithgow has put his hand up. Gavin, go for it.
I've a similar case in the sense that the person said, I'm visiting there, they're going to detox me and everything will be fine, but they've got no phone on at the property and I don't know the address, etc., etc. So you'd really want to tie it down to make sure there is something there. The 1 hour travel to the pharmacy is normal in the country, so I'm not sure that the brother is going to see that as a massive imposition, but it is a big imposition. So there may be a case for one takeaway, so 2 trips, so a total of 3 trips for the duration. But I only prescribe for people who are certified, stable, and sensible, and everybody's checked them out, and I'm not the first to start them. So I'd never see somebody coming out of jail 4 weeks. But if I was going to embark on that project, I need to know who his probation officer is, how's he going to do his probation, calling at this remote place, and the points about has he got a license, is fair, will the brother be driving, do I have permission to talk to the brother directly? But bottom line of it is, in my practice for the methadone prescribing, I would not be taking him on at this time, and be very diffident about sort of doing something very different to my normal practice so soon in the relationship. So I'd ask him to sort of, delay his trip with the brother till we got to know each other a bit better, and went from there. But otherwise, my experience with I'm going to go somewhere a long way away has always been a complete nonsense, and the trial of they never worked out. So I don't have a high regard for it. So yeah, I've been burnt a little bit, I guess.
Experienced.
So,
yeah.
Does anyone else want to put their hand up who has So I think some of the things that I'd encourage everyone to think about when making this kind of decision: how well do you know this patient? The way we've presented it is as if this is a guy that you've more or less never seen before and you really don't know much about him. And I think that's a big red flag if that is in fact the case. You know, people you don't know asking you for not huge favors, but huge liberties. I think that's a challenge. The second thing that we wanted you to keep in your mind is that this is an unusually high dose of methadone. It's not a world record, but it is quite a high dose, and the risks to adults are dose related. So if a opiate naive person took that dose, you know, most likelihood that person would die. So adult or child. So our decision making is partly influenced by the amount of methadone that we're talking about and how many takeaways. If this guy asked for 2 weeks of takeaways for a story like this, I think, you know, that would be a hard no. But if it was one day and it was a major family thing and maybe, you know, and you could substantiate it, maybe it's not such a hard no, maybe it's a yes.
Yeah.
There we go.
Great.
Stop there and move on.
Yes, let's move on to the next. So we're going to do this is the pre. So there was.
So just so everyone's aware, we had about 78% of people said no in this case.
But still about a fifth.
Yes, yeah, that's correct.
We're thinking yes. And we've not got the detail behind these answers. So it's just a bit of an impression.
Yes, yeah.
Okay.
We do have a comment from Angela who just wrote, I'm concerned that the brother's illness will be a further stressor on him. He might be having to assist his brother as well. So that could be another issue to consider.
Absolutely. Yeah. And I mean, it runs the spectrum from his long lost twin brother is at the point of death to a minor illness to maybe he doesn't even have a brother. So I mean, those who's been in the game for a while absolutely have encountered all of those kinds of situations. And does the brother have children and therefore a lockbox for takeaways? And are there children involved? And there usually are, and they're not always children that you know about. You know, maybe the brother doesn't have children, but maybe his girlfriend brings along her children from the, you know, previous relationship and so on and so on. So child safety is always in the background, if not the foreground.
Yeah. And the other point is also trying to, as you said, trying to get a bit of evidence that there's some facts around this story. Trying to gather whether, you know, there is the brother in the country and blah, blah. Mm-hmm. Okay, so we're moving on to the next slide now. Daniel, do we want to do it? Do we do a post?
Yeah, we can quickly run the post poll. Let's see if anyone's responses have changed or not, just out of curiosity. I'll immediately share the results. So same question, but just let us know, would you prescribe takeaways in this instance? And has your response changed? And if anyone's response has changed, was there a particular reason why?
Well, interesting. We've got. Oh wait, we've
got a few
couple
more
that haven't responded, but actually we can probably
can probably end it now, and
we can end it now. And basically, the number of people who would prescribe takeaways has gone down, and only 2 people said yes. Everyone else said no. So, you know, and we've talked about the questions, but I suppose the way of looking at it is if you had this information and you had no other information, then I would swing with the majority here and say, no, we need more information and we need that information to be favorable. And if it isn't, then probably no is a very good answer. Let's kick on.
Mm-hmm. Okay, number 2. So, Miss JK, a 58-year-old female on methadone 30 milligrams and 6 mils. She presents to you for a routine review and requests restoration of her previous takeaways. She was getting 2 + 2 a week. That was ceased 3 months ago. her takeaways were ceased because she had a presentation to the local hospital ED because of a fall, and that was apparently associated with intoxication related to benzodiazepines and alcohol consumption, which resulted in a fracture of her right wrist. So she wants to get her takeaways restored. So how do everybody feel about that? And in this case, what's important? What else would you like to know? And would you prescribe takeaways? And if not, how would you manage the patient's request?
And should I start the poll again, Sharon?
Yep. How are we going, Daniel?
We've got
We've
14.
got, yep, 16. Couple more people.
So I guess we could start talking. And
Yes.
so from our participants, what's your first thoughts about this in your decision making?
Hi, Shrida here. I said yes because we had only two options, yes or no. Personally, what I would do is I wouldn't be giving her 2 + 2. I would probably start with 1 + 1, spread out during the week and establish her stability. And even before I do that, I would have established her stability to, get her back on the takeaways.
Yeah. And how would you establish stability?
Her regular presentation, no evidence of further other substance use, her general overall presentation on stability, and taking into consideration other comorbidities, risk of falls, etc.
Yeah.
And we've had a couple of people in the comments say UDS results. Do we have any results regarding that? That could help guide.
Yeah, we don't have results, but getting one done's worthwhile consideration. I guess the only thing is sometimes they're a bit slow to come back, but that's okay. I mean, she could wait a little bit longer. Yeah, any other thoughts or anything else that we should do? The other thing I would think, maybe talking to the pharmacist as well, to see how she's presenting when she goes into pharmacy. Has she had any intoxicated presentations at the local pharmacy where she picks up?
It also looks like Chris has said the pre-dose BALs could be something to consider as well.
Yeah, yeah.
And check on SafeScript.
Yes, that's the other thing that's new, isn't it?
Yes, and Angela just wrote that as well at the same time. So
Yes, yes. So we want to know what she's doing with her benzos and
Yeah, but remember this population, about half the benzodiazepine use is non-prescribed. So, we should identify whether the benzos that she used 3 months ago were prescribed or non-prescribed. That'll give you a clue as to whether the odds are that it would be any different now. But I think 3 months is a fairly long time after takeaways have been removed. If she's got a couple of clear urines. And the other thing that we do in these situations is do a physical examination for track marks and active injecting. And if she's looks in reasonable condition, I think the comment made from someone to try one takeaway a week to begin with and see how that goes is a good step. And I've had quite a few patients like this because I work in a hospital setting where this is actually a pretty common scenario. I usually find patients accept getting one takeaway and then seeing how they progress and taking it from there.
Mm-hmm. What about the audience participants? Any other comments, or what might you do in your setting?
Okay.
Okay, move on.
Yeah, I think move on.
Okay.
So I'll just quickly share the results from the initial poll that everyone did. So 70% said that they wouldn't prescribe takeaways in this case.
Mm. It is a little bit more than the last case.
A little bit more than the last one, indeed. So there you go. And I'll quickly run the post poll as well.
Mm-hmm.
Just want to see if anyone's mind has changed following that discussion once again, whether or not you'd prescribe takeaways. About 3/4 of people have responded. And just while we're getting the last few in, Chris has said we may actually want to consider discussing depo-buprenorphine course, whether that could be an option for this patient.
Sure. Well, I think we've got 16 responses and the tide has in fact shifted a bit. We got 9 of 16, just over 50% have said, yeah, they would. And of course, it's not an all or none thing, and it's just a bit of an indication. But I think the message from this is a judicious and cautious reintroduction of takeaways might be reasonable. Just keeping our eye on the time, and why don't we just move on?
Yep. Okay, so Miss NW, a 29 years female on Suboxone, 24 milligrams sublingual daily. She gets 2 + 2 takeaways per week. She has just had her 3 children, 12, 8 and 3 years of old, returned to her care. For the last 2 years, the children were in the care of their maternal grandmother, who lives nearby and remains supportive of Miss NW and her children. Child Protection Services are also continuing to monitor Miss NW and her children's progress. Today, Miss NW requests an increase in her takeaways to 6 a week. Does that sound reasonable? And would you do that? Would you provide that? So how's that looking, Daniel?
I've got about 80% who've responded. Give it another 10 seconds or so.
Mm-hmm.
But there we are. We might end it there. And we can begin the discussion on this case scenario. So we've already got Gavin who said should consider after she's settled in with the children. Perhaps it's not something to consider to begin with.
Yeah, maybe not just rush into it.
Gavin, could we get you to explain your point of view on that one?
There was a reason the children were taken away, I trust. So she may or may not find the three kids, one of which is a young teenager, shall we say, stressing her out a little bit. They're likely to test her a bit. There's got to be some behavioural background issues to work their way through. So, and she still has to work out whether or not the kids are going to start ferreting for her takeaways or not. So there's just so many loose ends there that I'd be talking to her about keeping things the same in one department while she takes on a whole shed load of change elsewhere. And then we'll, when that's settled down, we'll make a change in the Suboxone department.
Okay, can I say that Rose Nelson's made an interesting point. Is Rose game to go off mute and explain her ideas there?
Well, I suppose I'm a case manager, so I'm not a prescriber. So I look at this case that you've got a supportive grandmother or her mother, you've got children.
Okay, I tell you one thing Rose does not have is an internet connection.
Actually,
maybe turn off your video, Rose, and see with the audio alone.
Rose did also mention that she's in a rural area, so she did say her internet was a bit sketchy when she messaged me earlier. So that might be the case.
I'm sorry about that, because she was right on a roll there, and hopefully we can come back to her. But we also had an interesting comment from Sridhar. Forgive me if I've got your name wrong, but Sridhar, are you able to go off mute and explain your point?
Yes, thanks for the wait. I would be questioning why now? Why when I think 3 children returning to her care, it's not a decision that would have been taken lightly. There would have been a lot of deliberations, including multidisciplinary teams, to come to this point. So if she was doing so well, she should have been already on 6 takeaways while this was all going on. And I just don't find the timing, it doesn't sit comfortably with me that this has to happen just when the children are returning. There's more responsibility on her, there's added stress to manage children, although she has other supports. I think managing her takeaways would just, make it more kind of a responsibility on her shoulders to kind of put up with that too. While I can also see the other side, that it gives her a bit of more time and freedom. But I think in this day and age, we would probably also consider getting her onto the depot if that's the case. But I just don't see the timing right to kind of go for 6 takeaways at this stage.
Yeah, I think that's a very good discussion. I have to say that I can't see any or almost no indication for 6 takeaways of Suboxone per day now that we're in the depot era where we can give people monthly shots, weekly at the least, and if someone is concerned about the impost of attending for dosing, then the depot is right out there. And if she's on 24 milligrams, that's a proper solid whack of Suboxone. Now, Caitlin, okay. What's the first name and what's the last name?
Just to cause confusion, Sue is my surname.
Okay. Well, Caitlin, apologies, but
all good. Like Rose, I work out in a rural area. Well, sorry, I'm not a prescriber. I'm a clinician, and I also work in a rural area at Wagga Wagga. I think for this woman, like, I have children almost exactly the same ages, and I don't know how I would afford to dose every day with 3 small children returning to my home with the cost. And I think Buvidal would be something, at least I think our team would be really strongly encouraging her to consider. I think it would also mean that she would be in reasonably regularly to our team for that to be given. So we would have eyes on her and be able to see if maybe the wheels were falling off a little bit and maybe offer a bit more support.
And I think Caitlin brought up a really good point there, because my understanding is a lot of regional areas, they don't have public dosing. And so if they're going to a private pharmacy, that is an additional cost, which, can someone bear that?
We have pharmacies charging $80 a fortnight for people to dose. So Buvidal for the consumers that I manage, at least, is the only free option for dosing.
Yeah, $80 a fortnight is, I can tell you, is country prices. City prices can easily be worse. But that's not to dismiss the high cost at all. Chris, did you have your hand up?
Oh yeah, so I do some telehealth clinics out in Murrumbidgee, and so there is some public dosing points, but they tend to be in emergency departments. So you can go in, and that would only be for daily dosing. They wouldn't do takeaways. But yeah, so if anyone wants takeaways, it's private through the pharmacy, in my experience.
Yeah, but you know, that's undoubtedly helpful, but there's no doubt that regional areas have a big problem with accessing dosing, of course, and that the Buvidal injection of once a month must be life-saving and must be making a huge difference. Caitlin's nodding. Tell us a bit more, Caitlin.
We lost our free public dosing point like September last year, something like that. And we were really sure we were going to have a whole stack of people jump off the program, which surprisingly we didn't. But we had more than I expected also just migrate towards Buvidal. And it's made a massive difference because we cover such a huge patch, and I have 80 consumers that are just little old me. So trying to manage the high number of people that I have, when they come in for Buvidal, I'm seeing them once a month. I'm kind of meeting some of those goals, building better rapport with people, and kind of catching those little bits and pieces here and there. Whereas without any kind of public dosing, in particular Buvidal, I can go months without seeing people. They just don't want to engage. They just want their dose, or be left alone. So the Buvidal's been great for us. It's stabilized loads of people.
Do you have problems with people not keeping their appointments, turning up for the next shot a week late or 2 weeks late?
Yes, every week. Constantly.
Yes, I think in inverted commas it's too good sometimes. They don't go into withdrawal if they miss a day or even a week. In many cases, they don't go into withdrawal, and consequently, they either forget or defer coming in.
We have a very robust text messaging system.
Yeah.
Because our clinic was on a Wednesday, so every Tuesday, last thing, the job is to text everyone who's due to come in the next day and be like, don't forget, you have to come in tomorrow and have your Buvidal.
So you do the dosing all on a Wednesday? Is that what you just said?
Yeah. Just because there's only one, I'm the only OTP clinician in Wagga at the moment, so I have to find a buddy to help me, and it's just easier if I can go, everyone's due to come in on this day. Just helps save my brain.
Yeah.
And so how many do you wind up doing in a single day?
The most we've done in a day is probably 15.
That's a solid.
And that's in an hour and a half kind of gap. So we have to spread out when there's extra people.
It's really interesting because you don't think Wagga is a massive busy place, but it is on Wednesdays, it would seem.
So yeah. Shall we
also have prescribers, so you get 80 isn't the total for us. 80 is just what's in the public program.
Yeah.
So do we need to do the post poll, Daniel? This is
why don't we?
Yeah, so we had 67% say no in the first case, and I'll quickly start the post discussion poll. Some very interesting insights, Caitlin, as well. So thank you for sharing that. That was wonderful. And we've got about 85% of people that have responded. So I might end the poll for brevity and share the results. And we now have 82% who said no, that they wouldn't provide takeaways in this case.
Yeah, so I think the discussion has led in the direction I was thinking myself, which is that this is not a great case for takeaways in quality because of the clinical issues, in quantity because she's already getting 4, and given the fact that there's a very good alternative that probably would be the right thing for her.
Okay, one more case. I think we've got time. Just trying to get it to move. Oh, you go. So scenario 4, Mr. AM is a 35-year-old male who's prescribed Suboxone 24 milligrams daily for back pain and has previous opioid prescription dependence He currently has 1 supervised dose and 13 takeaways dispensed every 2 weeks by his local pharmacy. He's planning to travel overseas for 4 weeks, visiting various family members throughout the United Kingdom, and requests takeaways for his travel. So the question is, would you provide takeaways? What case details are important? Anything else you want to know?
And we're running the poll now. About half have responded. Okay. 85% have responded. So I'll let that run for another minute, but we can begin the discussion.
Yep. So what does everybody think? Has anyone not said anything, but they like to say something? Raise your hand, wave your arms.
Or has anyone prescribed takeaways for someone traveling overseas in the past?
So this is where I tend to just pick on people. This is what happens if you don't talk. I pick on you. Hey, now Rose Nelson, are you back there? I don't think so. I think we really lost her. What about Guy Windsor? Hasn't said a thing, on silent, on mute. Guy, are you able to dip back in? No takers?
Oh, there's Guy.
There's Guy. Yay.
Have to unmute Guy.
Now you're unmute, but we can't hear you. The microphone is not working. Guy, I'm really sorry, but we're not hearing you. What about Rose? Go back to Rose. I can see Rose now. Can you unmute Rose? And
So no one sort of mentioned urine drug screens, and I don't mean to be punitive, but and we don't like to be punitive, but is that something we look at as well over time? If you're considering all these takeaways for overseas, what are their urine drug screens like? You're obviously getting all the information of, flights, where they're going to, are they authorised in a certain country or to the UK to take it in? You've also got to provide a letter to them for the flight. You'd need to be really sure that this person, is stable, and, it's certainly, have you seen their itinerary for their UK trip? All of those things.
Thank you, Rose. They're really good discussion. So, does anyone else have experience of patients going overseas who are on the opiate treatment program?
I'm not sure. Does Tasmania count?
Yes.
I swapped my patient over to injectable. Well, actually, I didn't, because Tasmania didn't have it then. So I did give her 28 days takeaway because she had to do all the COVID quarantine, etc. But then the plan was to get her onto injectable buprenorphine as soon as Tasmania had it.
Yeah, so I've certainly, I think this guy's screaming out to have Suboxone, and even if he was a little bit resistant to it before, this is a reminder that Suboxone, if there's time to prepare him for it, to get him on it before he goes away, it has the advantage of he doesn't have to take any medications with him at all. There's no paperwork, there's no risk. He can't lose them, he can't get them stolen, and he's not going to be in a crisis where in the middle of the weekend in some small town in UK, he's got to, go to the emergency department or throw himself at the mercy of a total stranger. So I think there's any number of reasons why the Buvidal or the Sublocade, the depot product would be a huge boon. And of course, if we're going to put him on it, you've got to give someone a couple of months, probably 3 months, to stabilize on it before you could confidently just go overseas and expect that to be without any problems. So plenty of my patients take a fair bit of time to get used to it. And in fact, just today I've had one give up on it and frankly give up on me as a doctor as well at the same time. So I would not be just injecting him and then putting him on the plane tomorrow morning. I think that's a bit problematic. I have to tell you that in my years of experience, I've never once, I give patients letter and explain all that stuff. I've never had a patient tell me, oh yes, somebody checked the letter. The first couple of times I did it, I was nervous and I wrote him a careful letter and I put my phone number and said, if anyone has a reason to contact me to confirm this, I'm at this hospital and here's my number. Not only have I never had a phone call, patients tell me they've never taken the letter out of the envelope.
We did have Mary, who's just messaged me. She mentioned that her microphone isn't working at the moment, unfortunately, but she did say that she has had 3 experiences so far with patients, often needing time to organise. All her patients are on methadone, obviously needing to change them over to the Phiseptone tablets in this case. They were all quite stable, and there was some discussion that need to be had with the pharmacy. Of course, need the itinerary, as we've mentioned, and the pharmacy needs time to get the tablets prior. So
yeah, so the chat also makes a comment that the patient was going to Egypt. So I don't know specifically the rules for Egypt, but there's a website where you check on all of the rules. You just Google it and you check on the rules for each country.
I think it's after here, isn't it?
But I have to tell you, my experience of it has been that the website's 20 years old. The rules are either old, not monitored, not kept. So you feel like you're doing the right thing to check that website. And, if someone's going to well, let's say if they're going to Egypt, I think one should, but check the website and do what it says. But I can tell you that I think it was Thailand where they said you had to inform the Ministry of Health and you had to do this and you had to do that. And we tried to follow those instructions and there was no interest from the other end. So don't expect that the other countries are passionately committed to the rules provided by their website.
I'm not sure if this is the website you're talking about, Paul, but this is
Indra.
Yeah, I got this off one of the experienced nurses downstairs that does a lot of this sort of checking and so it can provide a little bit of information, or you can talk to the embassy too, I guess, the relevant embassy of a
so you can turn this into a major expedition, and you can talk to the embassy. But then, first of all, how do you get someone from an embassy to answer the telephone? That would be my first question to you. Because it's almost impossible, and who's got time for it? So I think you check the website, give them the medications that they need, write a letter. And of course, you have to give them medications for a day or two before the flight and a day or two after they get back, both in terms if there's a delay, and also because they come home and they're exhausted and it's, you're giving them 2 weeks, give them an extra day and they can unpack and so on.
Alison's just asked a quick question. Would Phiseptone be an option in this case for people who are prescribed methadone, assumingly?
Absolutely. That would be the standard that's the standard. It's not absolutely mandatory that you do that, but tablets are much safer from being dropped and broken and lost than little bottles of liquid.
So I just wanted to show people, and we'll after this presentation we'll distribute a copy of the slides for you. But this is a copy of, and you probably can't read it very well, so when you get the slides you will, but it's a treatment agreement that we use at RPA for discussing safe storage of takeaways, and it has some good points that you need to consider, you know, warning about the fatality of opioid agonist treatment, and particularly outlining the patient's responsibilities and the prescriber's responsibilities, and, you know, witnessing a functional locked box or something similar. So you'll get access to that after the presentation. And basically now we're at the end and we've got 1 minute to go. So do you want to wrap up, Paul?
I'll just quickly share the results from the last poll as well, because we actually didn't go through that. 2/3 said that they would prescribe takeaways for that fourth case. So
okay, and 1/3 said they wouldn't. I'm hoping most of those were saying that on the basis that they'd put the chap on the Buvidal. I think it's important to remember that methadone's tough and onerous for patients, and one should try and be as generous as one can reasonably be, noting that there are plenty of cases where you shouldn't be too generous. So the summary dot points are that the dosing conditions vary according to the benefits and risks of the patient, service, and the broader community. And guidelines aim to strike that balance. And dosing decisions are based on the phase of treatment, the medicine involved and its dose, and a risk assessment about the patient and the circumstances. And that you can go outside the guidelines, but if you do, it is a clinical decision, and that for your protection, it strongly urge you to document it. You know, it doesn't have to be a 4-page essay, but you made a decision. This was your reason. You thought it was safe and reasonable. And if you've thought about it and tried to make a balanced and reasonable decision, the odds are then that's exactly what you've done. Excuse me, sorry. But
yeah, so I'm just flicking to the final slide.
Yeah, great. So I think Sharon and Daniel and I want to thank you for your participation. We want to end on time. Thank you. Look forward to seeing you again. The next session you can see 25th of October, and we will be asking the people on this list to give us a short case vignette for discussion. The intention as we go forward is that the cases come from the community of prescribers and treating centres, and that the discussant is going to be similarly shared around between the experienced prescribers and experienced GPs from around the state. We sort of took ownership of this just for the beginning, but as we move forward, we absolutely want this to be more of a community of prescribing activity. But the only way we'll finish on time is if I stop. So thank everybody for their participation, and hope to see you next time.